How's it going, guys? We have a pass level question for Hematology, Step 1 Internal Medicine 2CK. I gave you no vignette here because this smear is exceedingly high yield. It's in my Hematology PDF, shows up on the NBME exams. So, question just wants to know which of the following is most likely explanation for the patient's findings. I don't want you using a vignette here as a crutch for what this image is showing. So let's just hop through. Choice A, increased Luke's alkaline phosphatase, wrong fucking answer. This image is showing us neutrophilia. These are just neutrophils. Okay, so high neutrophils. And they're not hypersegmented. I'll ask students, what are you looking at here? And sometimes they'll say hypersegmented neutrophils. They're not hypersegmented. Okay, 5 lobes is typical for neutrophils. Maybe you could say one of them is 6. Doesn't fucking matter. Okay, it's neutrophilia is what we're looking at. And this is going to be leukemoid reaction, very buzzy smear here. Now, OID, oid, means looks like but ain't. So it looks like leukemia, but it's not leukemia. What's normal leukocyte count? I'm asking you, watching this clip. What's the range for normal leukocytes? 4 to 11,000 per microliter. So if you have an infection, let's say, e.g. bacterial pneumonia, you could expect leukocytes to be 10,000, could be normal. 13,000, 18,000. Patient with ruptured appendix is septic, could be 23,000. But let's say patient has a leukocyte count above 30,000. You think, wow, that could be leukemia. Leukemia most of the time, you're going to have a super fucking elevated leukocyte count. So if a patient has an infection and the leukocyte count is greater than 30,000, you say, that could be leukemia. You do the bloods, and then you get a smear like this where it's just neutrophils. This is called reactive granulocytosis. You need to know that. It's another name for leukemoid reaction where it looks like leukemia, but it's not. You thought that it could be leukemia. Leukemoid reaction is an infection where you have a leukocyte count greater than 30,000. So it looks like leukemia on the bloods, but it's not. That's why we call it leukemoid reaction. So some of you are going to say, hold on a second, isn't leukocyte ALP increased in leukemoid reaction? The answer is yes, but that's not the most likely explanation for the leukemoid reaction. That's not what's causing the leukemoid reaction here. So yes, you would have an increased leukocyte ALP, but there's a better answer. Okay, let's just hop through. So choice B, increased production of hematopoietic stem cells, wrong fucking answer. This is a very buzzy answer choice for polycythemia vera. JAK2 mutation. It's a long discussion. The patient's going to always have high RBCs. So normal hematocrit, 12 or 13 to 17.5 grams per deciliter. And if it's higher, in combination with leukocytes and or platelets elevated, at least 2 of the 3 cell lines, RBCs, white blood cells, platelets, if at least 2 of those 3 cell lines are increased idiopathically, that's polycythemia vera, okay? EPO is actually suppressed in those patients due to negative feedback, but it's a JAK2 mutation. Don't confuse with reactive polycythemia or secondary polycythemia where only your RBCs are high. That could be lung disease where your oxygen tension is very low, the 80s or lower for saturation. It could be renal cell carcinoma that secretes EPO. Only your RBCs would be high. But choice B refers to polycythemia vera, nothing in relation to the smear, and coincidentally, leukocyte ALP is also increased in polycythemia vera. Wrong fucking answer. Choice C, actually real quick, I will say, polycythemia vera, a factoid you could know is they can get pruritus, generalized itchiness, after a shower due to basophilia. As I already said, wrong fucking answer. Choice C, increased release of leukocytes in bone marrow reserve pool. Correct answer. Very buzzy for leukemoid reaction. Shows up on the NBME exams. I see people sometimes mention this in the Telegram group as if it's a big deal, and I'm like, look at my fucking hematology PDF. I've written it right there. So we could have written the answer as just reactive granulocytosis. I've done that on my YouTube. 1,083 questions. I've made probably 3 questions where I have reactive granulocytosis as the answer. It's what we're looking at here. So as we said, leukemoid reaction is where you have an infection. Could be anything. Pyelonephritis, prostatitis, spontaneous bacterial peritonitis, doesn't fucking matter. Infection where your leukocyte count is greater than 30,000. You say, holy shit, that could be leukemia. You check the bloods, but rather than seeing leukemic cells, you see neutrophils. You see reactive granulocytosis. And the mechanism is increased bone marrow release of granulocytes from the post-mitotic reserve pool. Okay, that's what we have here. So let's just hop to the final ones. Reactive lymphocytosis, wrong fucking answer. So they're not lymphocytes. Reactive lymphocytosis could be an answer for pertussis, also lengthy discussion. So in a child, let's say 8 years old, who has a leukocyte count of 60,000, where it's 90% lymphocytes, you say that's ALL, acute lymphoblastic leukemia. However, I've talked about this, pertussis is an important differential for ALL because it can also cause a super elevated leukocyte count where it's all lymphocytes. So let's say they give you an 8-year-old and they say leukocyte count 40,000, 89% lymphocytes. You're like, oh, that's ALL. But they tell you there's paroxysms of cough, maybe immigrant status, which can mean unvaccinated status. They can say post-tussive emesis, vomiting after a cough, high yield for pertussis. Hypoglycemia can also be seen in pertussis. That's going to be pertussis, reactive lymphocytosis. ALL is the wrong answer. High yield for pediatrics, but you should know that for step 1 as well. Wrong fucking answer. Choice C, synthesis fusion protein, wrong fucking answer. Exceedingly high yield for CML. Chronic myelogenous leukemia, 922 translocation, BCR-ABL. It forms an oncogenic tyrosine kinase. And I've talked about how the NBME can write that as fusion protein. I really don't know what to tell you, okay? It's a buzzy answer choice for CML, okay? And the smear, as opposed to showing you reactive granulocytosis, neutrophilia, as we have here, will show you what I refer to as a motley mix or a soup, a medley of all different types of cells where you say, no idea what I'm looking at. But the whole image tends to be purple, all different types of cells. That's classic for CML. Okay, I've put the smear in my hematology PDF, which I'll link below. Fusion protein? Wrong fucking answer. You know the deal. To make more content, like myself, Differential. Appreciate your time. That's it.